So welcome to all the people attending this CPC organized by Dr. Raja of the North Zone ISN. Today evening's case is a renal transplant recipient who was admitted to the PGI and had a hospital stay of just 1 day before he expired. He had had a kidney transplant some 9 years earlier and developed numerous complications during the recent few years. Subsequently got admitted and died within 1 day after admission. Discussed by Dr. Gauri Shankar from the Department of Nephrology, PGI Chandigarh. Dr. Gauri Shankar, please.
Thank you, sir. Am I audible, sir?
Yes.
Hope my slides are visible, sir.
Yes.
Yes. Good evening, one and all. I'm Dr. Gauri Shankar, Senior Resident from the Department of Nephrology. I'll be presenting the clinical pathological case today. Moving on to the case, this 50-year-old gentleman who underwent live related renal allograft transplant in the year 2007, subsequently got diagnosed with post-transplant diabetes mellitus, new onset diabetes after transplant in the year of 2015. He had background chronic allograft dysfunction and his creatinine ranged from 2 to 2.5 milligram per deciliter before this current admission. In July 2016, creatinine rose from a baseline value of allograft biopsy, which was reported as having antibody-mediated rejection, for which he received 4 sessions of plasmapheresis, IVIG, and methylprednisolone. However, his disease process worsened and he was declared graft loss, and since September 2016, he was started on maintenance hemodialysis. His first hospital admission happened on 20th of September 2016. This time he presented to us with multiple episodes of loose stools and altered mental status. On emergency admission in ER, he was found to have lower blood pressures, and he was given IV fluids and was subjected to biochemical evaluation, which revealed pancytopenia, as you can note, with a HB of 6.3 and a platelet count of 45,000. He also had hypocalcemia and hypophosphatemia, a hypoalbuminemia ranging to the tune of 2.2 gram per deciliter. We can note phosphatase levels were elevated to 2 times the limit of normal, and multiple episodes. Stool examination and stool routine workup revealed no schistocytes. Bone marrow aspiration and biopsy revealed no hemophagocytosis of typical cells. For loose stools, stool routine were negative. Atypical organisms were not there. Stool CDTA was positive. He was subjected to CMV DNA PCR, which was positive, and colonic biopsy. So a pleural fluid was tapped, which was basically transitive in nature, and gram strain culture sensitivity was sterile, and fungal culture was not available. Ascitic fluid work was done because he had gross ascites at that point of time, which revealed 80 total count, which were predominantly polymorphs, and a SAG of around 1.7. We don't have any protein value to comment about the nature of the ascites per se. So he was subjected to sepsis workup. Multiple blood cultures and urine cultures were all sterile. Serum procalcitonin was elevated. The first value on 22nd of September was 9.9 nanogram per milliliter. Following therapy, serum procalcitonin reduced to a value of around 1.6. Serum galactomannan index was done, which was 0.29 optical density. As he had mixed hyperbilirubinemia, mixed jaundice picture, he was subjected to hepatitis workup. Hepatitis B surface antigen was negative. Hepatitis C viral and RNA levels were target not detectable. HIV, hepatitis A and E also negative. Ultrasound abdomen revealed a preserved liver size. However, there was coarse and decotexture, and portal vein was around 14 millimeters. There was gross ascites, and the transplant kidney was 9.6 centimeter with some raised cortical echogenicity. He was subjected to CT chest as he had hypoxia as well as pneumonia, which revealed patchy consolidation with few nodules in right upper lobe and in the left lower lobe, query infective etiology, with bilateral moderate pleural effusion, mild pericardial effusion, and pulmonary arterial hypertension. A repeat HRCT chest was obtained after therapy. Cardiomyopathy with multiple episodes of cough, shortness of breath, and dyspnea. And at this point of time, during emergency admission, he was found to be tachycardic. He was hypoxic with a saturation of 81% on room air, and he was hypotensive with a blood pressure of 70 millimeters of mercury systolic. His GCS was E4, V5, M6 dull, and chest examination revealed bilateral crepitations. Biochemical investigations and the routine investigations revealed leukocytosis to the tune of 23,000 cells per millimeter cube and platelet count of 79,000. He had deranged RFTs and he still had hyperbilirubinemia, which was mixed picture. However, it was on a decreasing trend. He had a PTI value of around 50% and blood gas analysis revealed near normal values. As he had hypotension, he was with a possibility of LRTI, which was going on. A septic shock possibility was considered. He was started on piperacillin, tazobactam, and vancomycin and inotropes. However, within heart, he succumbed to cardiac arrest, and the CPR was initiated as per ACLS protocol. However, he couldn't be revived. The unit's final diagnosis is live-related renal allograft transplant with acute and chronic allograft dysfunction. Acute factor being either rejection or infection, and a chronic factor being chronic rejection, acute and chronic liver failure, pneumonia, hospital-acquired infection with sepsis and septic shock. Cause of death being refractory septic shock. Points of discussion that I'll be dealing with right now will be cause of allograft loss, etiological possibility of LRTI, causes of ACLF and cholestatic jaundice, and the terminal event in this patient. We have both clinical as well as laboratory database. Clinical database being live renal allograft transplant in 2008, following that NODAD by 2015, ABMR by 2016, which was biopsy proven, for which he received some therapy. Following that, he succumbed to graft loss. And this time he has presented with fever with loose stools, which were treated, jaundice, which was mixed picture, and respiratory tract infection and shock. Laboratory parameters reveal pancytopenia, stool CDTA positivity, CMV DNA PCR positivity, colonic biopsy suggestive of CMV colitis, USG suggestive of CLD, cholestatic jaundice, which was predominantly intrahepatic, some pulmonary hypertension, HRCT revealing nodules and consolidation. Allograft dysfunction. The causes for allograft dysfunction in this case can be chronic rejection, a chronic viral infection, recurrence of basic disease, or chronic CNI nephrotoxicity for the chronic allograft dysfunction part. The points in favor of chronic rejection are a long post-transplant period of around 9 to 10 years, allograft dysfunction, which is present in this case, and a demonstrated ABMR at this point of time. However, the soft pointers of which were against a chronic rejection were the details of the allograft biopsy were not available currently, sensitization status was not known, compliance of the patient to the drugs were not known, the TSA titers were not available. BK virus nephropathy for a chronic viral infection. Points in favor are the presence of graft dysfunction and a recent treatment for rejection. However, the point against BK virus nephropathy are a longer time period post-transplant, and a soft pointer of allograft biopsy, which was not suggestive of BK virus nephropathy. Chronic CNI toxicity. Points in favor of chronic CNI toxicity are the presence of chronic allograft dysfunction and a long duration post-transplant period, which can be supported by the study which was published in NEJM by Chapman and Ankivel et al. However, the point against are the C0 levels were not available and no allograft biopsy features which were suggestive of CNI toxicity reported. Recurrence of the basic disease, the points in favor for it are the time period post-transplant, presence of allograft dysfunction. We have a urine examination value showing an albumin of 2+. However, we don't have any allograft biopsy which was suggestive of same, or a 24-hour urine protein quantification in this case was currently not available. For acute allograft dysfunction, the causes that can explain are acute rejection, The points in favor of it were acute raise in serum creatinine. We have a biopsy-proven ABMR and a presence of CMV disease. However, the point against or a long post-transplant period and absence of response with therapeutic plasma exchange, even though it's a soft pointer, and we as all know that around 30 to 40% of ABMR may not respond to therapeutic plasma exchange only. And presence of CMV disease, the points in favor of it are presence of GI symptoms, cytopenias, and pneumonia. We have a biopsy-proven CMV colitis antemortem. CMV DNA is PCR is positive, and we have response to ganciclovir therapy. However, the point against it is allograft biopsy was not suggestive of CMV disease. So by consolidating all the things which we were considered, the point of rejection seems to be highly likely. CNI toxicity seems to be unlikely. BT virus nephropathy can be a likely additive factor. Recurrent basic disease and diabetic nephropathy seems to be unlikely. CMV disease can be a likely cofactor. The next point to be considered is the presence of hepatic dysfunction. The etiological possibilities and the syndromic possibilities that I would like to consider is acute liver failure in this case. The points in favor of it are presence of jaundice, coagulopathy, encephalopathy, and the duration of less than 26 weeks. However, the points which were against were the presence of only mild transaminitis, AST more than ALT, presence of thrombocytopenia and hypoalbuminemia, which are synthetic functions of liver, USG showing coarse and decotexture and gross ascites, which was high SAG ascites. Point of acute and chronic liver failure. The points in favor of it were presence of jaundice, coagulopathy, hypoalbuminemia, thrombocytopenia, gross ascites, which was high SAG, and USG features suggestive of portal hypertension. However, the point against it were there was no previous hepatic decompensation, and one soft pointer was that the viral serologies were non-reactive. This is a consensus definition, which has been published in APASL for ACLF. ACLF is defined as any acute hepatic insult with jaundice more than 5 milligram per deciliter and a coagulopathy with INR more than 1.5 within 4 weeks. The patient is complicated by clinical ascites and or encephalopathy in either a previously diagnosed or an undiagnosed case of CLD. Our case fits the bill. And as per the severity classification of A or C consortium score, our case fits in the ACLF class 2. The acute precipitant in this case is likely sepsis, which can be LRTI or a CMV disease. Decompensated liver disease, however, the etiology of which is not known. We have decompensation in the form of ascites and encephalopathy. Possibility of CLD, our patient has bicytopenia, coarse liver, hyperalbuminemia with transaminitis, coagulopathy with high SAG ascites. However, we don't have any fibroscan or a UGI endoscopy which was done antemartem. The likely possibility I would like to consider, first possibility is non-alcoholic fatty liver disease as a patient is post-transplant with immunosuppression therapy, presence of NODAT and absent viral serology. However, the duration of NODAT of 1 year is a soft pointer which is against this etiology. Any atypical virus is causing CLD, as we have CMV PCR positivity. However, the pre-transplant CMV status and liver biopsies were not available, which were soft pointers against the viral etiologies per se. A surprise to us will be the presence of autoimmune hepatitis. As the patient has not got any alcohol consumption, we have absent viral markers with CLD with bicytopenia. However, the point against it is liver biopsy is not available, autoimmune markers were not available, and IgG levels were not available. Likely and a rare possibility of chronic hepatitis B infection causing CLD, however, in this case could not be negotiated. The acute event in this case can be sepsis or CMV. The points in favor of sepsis is leukocytosis, presence of pneumonia, and a high procalcitonin level. There are no points which says against the cause of sepsis as an acute precipitant. For CMV as a precipitant, the points in favor are a post-transplant setting. We have CMV DNA PCR positivity antemortem. We have all the trilineage symptoms, GI symptoms, cytopenias, and pneumonia in this patient. The point which is against CMV per se is high alkaline phosphatase level. As it is a post-transplant patient with some cholestatic picture, a rare possibility of fibrosing cholestatic hepatitis, I would like to consider. The point in favor of it are post-live renal related allograft transplant with CMV DNA PCR positivity, presence of jaundice, and high alkaline phosphatase levels. A long post-transplant period, however, would be a soft pointer, which is against the possibility of fibrosing cholestatic hepatitis. The point to be noted is that the presence of decompensation is very rare, and it is unlikely to happen in fibrosing cholestatic hepatitis per se. As our patient has septic hepatopathy, a possibility of septic hepatopathy should also be considered. The points in favor of the presence of leukocytosis and leukopenia, coagulopathy, respiratory tract infection, and raised ALP levels, which itself can happen in sepsis. However, the point against are the presence of USG features of portal hypertension and features of liver failure, which itself cannot happen in septic hepatopathy per se. Consolidating all the findings in the liver, the possibility of ALF seems to be unlikely because this doesn't fit the bill of ALF. We have features of chronic liver disease in ultrasound. ACLF seems to be highly likely, and a fibrosing cholestatic hepatitis seems to be a less likely factor. Sepsis seems to be a likely cofactor. Drug-induced cholestasis, even though has to be considered a possibility, seems to be rare. PTLD in this setting seems to be unlikely. For a respiratory infection, I'd like to keep the first possibility of a bacterial infection. The points in favor of bacterial infection are cough with expectoration, leukocytosis with procalcitonin raise, CT shows consolidation, and there was some response to antibiotics. However, the points against it is documented worsening on antibiotics and presence of some nodular lesion in CT chest, which is a pointer. Presence of fungal infection, the points in favor are a post-transplant setting. Patient is on maintenance immunosuppression therapy, recently received anti-rejection therapy, graft loss, neutropenic, recent antibiotics abuse, and presence of diabetes mellitus. However, the point against it, a soft pointer which is against it, is being serum galactomannan levels being normal. This was a systematic review which was published by Muscat et al. In Critical Care Medicine. Our patient fits most of the risk factors which have been explained in this study for an invasive fungal infection. And an article which was published from our very own department. It has looked up into 850 post-renal transplant patients. Systemic fungal infection were present in 10% of the patients in this study, and invasive fungal infection was present in 52% in autopsy series in this study. And CMV disease as a possibility for LRTA, as the patient had post-renal transplant and CMV DNA PCR was positive, presence of GI symptoms and cytopenias, we had nodular lesions in CT chest. However, the point against or secondary worsening as the patient has received ganciclovir, and a soft pointer which is against CMV is the presence of pleural effusion. One would not be surprised if a possibility of CCF should be considered, because we have a post-transplant setting with post-transplant diabetes mellitus, presence of bilateral pleural effusion, which is transitive predominantly, a high sinusitis with a normal liver size, and presence of pulmonary hypertension, likely secondary. However, we don't have any features of pedal edema or other features to suggest congestive cardiac failure in this case. Next, another rare possibility will be to find an infective endocarditis, as we have a post-transplant graft loss on maintenance hemodialysis, cough with expectoration, and there was some central venous catheter use. However, the point against it, there was no fever documented at this point of time, and blood culture was sterile and echo was not available. These two events seems to be less likely. The terminal event in the case actually presented with shock. Possibility for this, I would like to consider a septic shock, because he had cough with expectoration with leukocytosis and radiological evidence of pneumonia, and the likely etiological possibility would be fungus or an MDR bacteria or a viral. Second possibility would be a cardiogenic shock, as he had features of biventricular failure. However, there was no ECG, echo, or cardiac biomarkers available to prove the same. And a third less likely possibility that I would like to consider is pulmonary thromboembolism, as he had recent history of immobilization, history of dyspnea with cough, and he has severe hypoalbuminemia. However, we don't have any cardiac biomarkers available, ECG, echo not available, and lung auscultation reveal bilateral crepitations. Risk in this case comes to be 3, which is an intermediate risk score, and a PTE seems to be a less likely event in this. Final diagnosis that I would like to consider is live renal-related allograft recipient, basic disease being not known, new onset diabetes after transplant, allograft dysfunction, the cause of it being acute on chronic rejection, leading on to graft loss, liver failure, likely acute on chronic liver failure, acute precipitant likely being CMV or a sepsis, likely source being LRTA, a chronic factor of non-alcoholic fatty liver disease or a chronic viral infection, Clostridium difficile associated diarrhea, which is treated, CMV disease in the form of cytopenia is GI, lung, query vasculopathy with pulmonary hypertension manifestation, sepsis, foci being lung, and etiological possibility likely polymicrobial, fungal, bacterial, and viral, anemia likely multifactorial, infection, nutrition, and renal failure related, and malnutrition. Autopsy findings expected in this case would be lung, MDR bacteria or fungal or CMV infection, plus minus signs of cardiac failure. Cardiovascular system, I would like to find cardiomyopathy, ischemic cardiomyopathy likely, pulmonary artery to show features of CMV viral cytopathy, renal chronic active ABMR, CMV viral inclusions, liver periportal fibrosis, cholestasis in the canalicular or hepatocellular areas, and CMV infection. Thank you.
Thank you very much, Dr. Gauri Shankar, for an exhaustive analysis of the events. Just a few small points. One point regarding the use of the term NODAT. Generally, the term should be applied only to cases of diabetes mellitus developing soon after transplantation, within the first 6 to 12 months. In this patient, it developed something like 8 years after transplant. So it's better to call it just post-transplant diabetes mellitus rather than NODAT. One question for you, I wanted to be clear. When was ganciclovir started, and when was the course of therapy completed in relation to his demise?
Sir, the exact date of initiation of ganciclovir is not available in the CPC protocol per se, sir. But however, it is likely that post biopsy and CMV DNA PCR positivity, he would likely have been started on ganciclovir, sir.
So any rough idea, did he get 4 weeks of therapy or how much?
The same was not available in the protocol per se, sir.
And was he totally off immunosuppression now?
We have no details available of, regarding the immunosuppression therapy right now in the protocol per se.
Yeah, because I would presume that he would be off, except maybe steroids, because he had graft loss already.
Yes, sir.
Okay, so with that, we can go on to open the discussion to all the delegates, all of those attending. You're welcome to give your comments or your opinions on the possible diagnostic possibilities.
So there are a few opinions, sir. I'll read them out for you.
Yes, yes.
If it is okay. First one is acute liver failure with cholestatic picture. Could this be TB hepatitis?
EB, Epstein-Barr.
Tuberculosis, sir. Tuberculosis with hepatitis. The hepatitis due to tuberculosis.
Tuberculosis, okay, right.
This is one of the possibilities. The second is another comment is about, could there be an additional tuberculosis in this patient? And then the third comment is, why do you think there is a remote possibility of recurrence of the kidney disease after graft loss? Probably he means, Dr. Gauri meant it was one of the additive factors leading to graft loss rather than the recurrence being diagnosed at graft loss. Many people are asking about tuberculosis only. Is there a possibility of tuberculosis? Well, I think only the time would tell if there is an additional tuberculosis. Then there is another interesting question. What was the access through which the patient was getting dialyzed after graft failure? Unfortunately, in the protocol that was provided, we do not have those details. We believe that it could have been through a temporary catheter or through a fistula, although a fistula is less likely the way the patient was sick and other thing. But anyway, we do not have that aspect.
Sir, can I?
Yeah,
So regarding the tubercular hepatitis, a granulomatous hepatitis form of tuberculosis can present in this way, but for tubercular hepatitis per se to present with acute decompensation or a chronic liver failure is very rare of a possibility. So tubercular hepatitis per se to cause acute and chronic liver failure, no, but granulomatous hepatitis with tuberculosis can be considered as a possibility.
Yes, especially the alkaline with elevated alkaline phosphatase. Would it be resistant CMV and fungal etiology is the next comment that has been made.
Regarding the fungal etiology, fungus is highly likely on the cards because we have, as we have projected in the presentation, he had multiple risk factors for fungal infection per se. For a resistant CMV disease, the patient lose stools, the GI symptoms have completely disappeared post initiation of IV gancyclovir therapy, and there was resolution of some amount of hyperbilirubinemia post initiation of this therapy. To consider resistant CMV disease at this juncture would be a less likely event.
So
I would ask
we
what
don't.
what
We don't seem to be having more any more suggestions or comments. Dr. Raja, anything else?
I'm just asking you, sir, like what would you think, what do you expect there could be in the autopsy, or what do you think, which kind of infections could this be?
Well, I think CMV incompletely treated is still one possibility. I don't think I can rule that out completely, and we are not really sure of the duration of therapy. Bacterial and fungal infection are additional possibilities. In transplant recipients, particularly at autopsy, we have often seen multiple infections coexisting in the same patient. And so I don't think I can rule out either bacterial or fungal infections or even associated tuberculosis, which has been suggested. So I think those possibilities still remain. And there is the basic setting of graft loss due to ABMR, and of course, there is chronic liver disease.
Yes.
So that's what I feel we are dealing with.
Okay. There's one last comment, sir. There is the patient had arrived to the emergency with hypotension without acidosis. Could there be a pulmonary thromboembolism causing this?
Yes, Dr. Gauri Shankar had also considered that possibility,
yes,
but kept it as relatively less likely.
It was an ambulant patient. I think it's we are
I think
comments, so we can.
If we can go ahead with the pathology findings, for which I'd like to invite Dr. Jesty Tom from the Department of Pathology, PGI, to show us the autopsy findings.
I think we have 3 chairpersons as pathologists, so they're going to provide key insights again, along with Dr. Jesty.
Good evening, everyone. Sir, am I audible and my screen visible?
Yes.
Yes. Thank you, sir. So let's move on to the pathology protocol of this case. So in this 50-year-old male who had a hospital stay of 1 day in his last admission, he had a clinical, he is a post-transplant patient who underwent renal transplant in 2007. And he had a clinical diagnosis of acute on chronic allograft dysfunction, acute on chronic liver failure, pneumonia with sepsis and septic shock. So a complete autopsy was performed and the prosectors noted that there is around 1000 ml of yellowish fluid in the peritoneal cavity. However, the pleural and the pericardial cavity were within normal limits. So before moving on to the postmortem findings, let's have a look at the antemortem colonic biopsy. So the colonic biopsy was in 3 fragments, and these are the representative images of the colonic biopsy. So before discussing the findings in this biopsy, let's see how a normal colonic biopsy looks like. So here we can see that in a normal colonic biopsy, we can see the crypts are arranged parallel to each other, giving a test tube kind of appearance. And these crypts are they are lying on the muscularis mucosa. So when we compare with this histology with our current biopsy or the biopsy of our patient, here we can see that there is loss of the crypts with replacement fibrosis. So this is indicating chronic colitis. And one of the fragment was showing granulation tissue. So on further higher magnification, we were able to identify some large cells with nucleomegaly in the endothelial cells and some of the stromal cells. And these cells were showing smudgy nucleus, indicating CMV inclusions. And these were confirmed on IHC for CMV. So a diagnosis of CMV colitis was given. So since we have an antemortem diagnosis of CMV colitis, in the postmortem findings, let's have a look at the GIT first. So here we can see this is the esophagus, stomach, small intestine, and large intestine. And grossly, they were unremarkable. And this is a representative image, photomicrograph from the intestine. Here we can see that there is a marked submucosal fibrosis. Here, this is a higher view to show the submucosal fibrosis, and we can see that there are some dilated and congested vessels also. The fibrosis is highlighted in this Mason's trichome stain. So Pearl stain was also performed, and here we can see that there is some evidence of chronic hemorrhage. As we can see that this bluish color, which represents the hemosiderin-laden macrophages. So this may be due to healed CMV colitis. However, we were not able to demonstrate any CMV in the postmortem GI samples, which may be attributed to the response to the therapy. So moving on to the next organ complex, here we can see these are the native kidneys, aorta, the transplanted kidney, and the urinary bladder. So on higher magnification, here we can see the native kidneys are markedly shrunken, and it weighs around 75 grams. The capsular aspect does not show any focal lesions or any other pathology, any other lesions. And on the cut surface, we can see that the cortex is markedly thinned out, and there is increase in the intrarenal fat, and there is a dilatation of the pelvic calcial system. And in addition, we can see that there are some atherosclerotic plaques in the aorta. So moving on to the microscopy, here in H&D stain, here we can see that it is very difficult to appreciate the glomeruli. We can see that these glomeruli, the globally sclerosed glomeruli are actually melting into the markedly fibrosed interstitium. However, this globally sclerosed glomeruli are highlighted in this PA stain, and here we can see that there is marked approximation of the glomeruli, and the marked interstitial fibrosis is again highlighted by this Mason's trichome stain. In addition, there was marked arteriosclerosis, which is in the form of there is marked in the fibroendymal thickening and duplication of the internal elastic lamina, which is highlighted by this EVG stain. So in the native kidney, we have end-stage chronic renal disease changes. So we were not able to demonstrate any basic disease in the same. So moving on to the transplant kidney, this is the capsular aspect, which is showing some cortical cyst. Otherwise, there was no other focal lesions. And the cut surface, we can show that the corticomedullary junction is indistinct, and there is mild increase in the intrapelvic fat. So this is a closer view to see the anastomotic site, and we can see that the anastomotic site is patent. Now moving on to the histology. So in the histology, we have both chronic and acute changes. So we will see both the acute and the chronic changes in all compartments one by one. So first, let's see the changes, acute changes that is present in the glomeruli. So the glomeruli shows glomerulitis in the form of infiltration of leukocytes, occluding the capillary lumen, occluding the capillary lumen. So this was present in around 30 to 40% of the glomeruli, giving a glomerulitis score of 2. In addition to the glomerulitis, we can see that in the mesangium, it is giving a fluffy look. That is, it is looking a foamy kind of appearance, which is seen in acute thrombotic microangiopathy. So in MSB stain, we can see that there is fibrin deposition both in the afferent arterioles as well as in the capillary wall. This is indicated by this orangish reddish color. So we have glomerulitis G2 and acute thrombotic microangiopathy. Now moving on to the chronic features that is present in the glomeruli, here we can see that there is double contouring of the glomerular basement membrane, which is appreciated here also in the John stain. This indicate transplant glomerulopathy because it is because of repeated endothelial injury and healing process. There is double contouring. So in addition to the this finding, there were some of the glomeruli were also showing mesangial matrix expansion, and also there is focal segmental sclerosis also. This was again highlighted in this John stain. So we have chronic TMA changes and transplant glomerulopathy. So these are the electron microscope photograph, which is showing the glomerular changes. Here we can see these are here this photograph demonstrates the TMA, acute TMA. Here we can see that this is the basement membrane. This is the podocyte, and here we can see there is marked endothelial swelling. So this is photograph shows the transplant glomerulopathy. Here we can see the double contouring. This is the old basement membrane, and here you can see the new basement membrane formation. So we have chronic active ABMR. So moving on to the next compartment, that is a tubulointerstitial compartment. When we look at the tubules, there is no tubulitis in the non-severely atrophic tubules. And the interstitium is not the non-scarred area in the interstitium in the non-scarred cortex is not showing any significant inflammation. However, we can see that there is some peritubular capillary dilatation and margination with a score of PTC 2. So we have no tubulitis and we have a PTC 2. So electron microscopy was performed, and to look at if there is any multi-layering of the basement membrane of peritubular capillaries which were not present. C4D was performed, and it was positive in the peritubular capillaries, indicating ABMR. Now continuing with the tubulointerstitium, here we can see that there is no significant inflammation in the non-scarred cortex, and the IFTA is around 40 to 45%. So we have we have a scores of I0, IFTA 2, CT2, CI2, and total inflammation 2. So moving on to the fourth compartment, that is the arteries and arterioles. Here we can see that there is circumferential arteriolar hyalinosis with a score of AH3, and there was evidence of transplant arteriopathy. Here we can see that there is marked fibrointimal thickening, which is completely occluding the arterial lumen. So we have a transplant arteriopathy with CV score 3. In addition to the transplant arteriopathy, we also had features of arteriosclerosis, which is again demonstrated here. There is fibrointimal thickening, and there is duplication of the internal elastic lamina. So summarizing the findings in the allograft kidney, we have C4D positive chronic active ABMR with secondary segmental sclerosis with the Banner's criteria scores G2, C3, CG3 and MM2. So the patient presented with breathlessness in his last admission. So let's move on to the lungs next. So the lungs are heavy, weighing around 1,070 grams. The pleural surface, it shows some exaggerated pleural marking, and focally there were some fibrinous tags. The cut surface shows some patchy areas of consolidation. There were no emboli in the pulmonary vasculature. Now coming to the microscopy, this is a low power view to show the changes in the lung. And in the low power itself, the striking is there is some dense inflammation going on here. So let's have a higher look at the higher power. Here we can see a bronchiole which is filled with this dense mixed inflammatory infiltrate. And when we look at here, we can see that there is the denudation of the lining epithelium, and there is break in the wall, and we can see that this inflammation is spilling into the adjacent lung parenchyma, and it is filling the alveolar spaces, indicating there is bronchopneumonia. So at a closer view, we can see that there are many scattered multinucleated giant cells in this inflammation, And on further higher view, we can see that there are some fungal profiles which is present in this multinucleated giant cells. So we can see that these fungal profiles are having some brown pigment. This is the PA stain to highlight the fungal profiles. And at higher power, we can appreciate the morphology of this fungus. So we can see that they are slender, they are septate with acute angle branching, and they are having some bulbous ends. So this is confirmed with the morphology of pheohypomycosis. The Grocott stain again highlighting the same. And some of the vessels were also showing the presence of these multinucleated giant cells and presence of these fungal hyphae inside these multinucleated giant cells. So the tissue was submitted for molecular identification of the species of the fungus, and it was found to be alternata, courtesy to the mycology department. So we have in lung, we have a bronchopneumonia due to pheohypomycosis. However, there was no granulomas or any evidence to suggest any tuberculosis, or there was no evidence of any pulmonary embolism. So moving on to the next organ complex. This is an organ complex comprising of slice of liver, pancreas, seed loop of duodenum, and a slice of spleen. So the liver weighed 1,300 grams. The capsular aspect was unremarkable. There was no focal lesions or any nodularity. However, the cut surface, we can see that there is some dark and light stained areas giving a nutmeg kind of appearance. This is a representative photomicrograph. Here we can see that there is no significant fibrosis or any bridging fibrosis seen. What we can appreciate here is there are some light stained areas and there are some dark stained areas. And these light stained areas are mostly, they are centrisonal. So these light stained areas indicate hepatic necrosis. So this is again appreciated in this mesenchymal stain. And here we can see that there is no significant any portal in fibrosis or any bridging fibrosis. The reticulin stain, we can see that there is a collapse of the reticulin network at the those areas where we have hepatic necrosis and loss. With these changes can be attributed to the pre-terminal events. And in addition to this, we also have extensive cholestasis, which may be attributed to the septicemia changes. However, there was no granulomatous pathology in the liver. This is a representative photomicrograph from the pancreas, which does not show any significant, any specific pathology. The IHC for CMV was performed in liver, kidneys, and pancreas. All were negative. This is just a positive control. So moving on to the next organ, heart. The heart weighed 340 grams, and it shows there is mild rounding of the apex, and there is mild increase in the epicardial fat. The heart was opened by modified inflow-outflow technique. And here we can see that grossly as well as microscopically, there was no significant pathology in the heart. This is a representative photomicrograph from the postmortem trephine biopsy of bone marrow. And here we can see that there is adequate representation of the all three hematopoietic lineage elements. All other organs, including the brain, was grossly as well as microscopically did not show any significant pathology or any involvement by the fungal infection. So the final autopsy diagnosis in these cases, in the allograft kidney, we have C4D positive chronic active ABMR, bronchopneumonia, fungal in the lung, centrisonal necrosis with septicemic changes in the liver, and the intestine shows submucosal fibrosis with old hemorrhage. Looking into the some literature, there were many case series and case reports of pheohypomycosis in post-solid organ transplant cases, including the kidney. And in all these studies, we can see that most of these infections were restricted to the subcutaneous tissue, and the invasive pathology or the systemic involvement was very, very less frequent. Like in this study, there were only 2 cases with pneumonia and 1 with brain involvement. This is again another study which is showing the same. There were 27 cases, among which only 3 were pulmonary and presented the other with brain abscess. This study compared between the stem cell transplant and the solid organ transplant patients, and they found that this cutaneous infection was more common in solid organ transplant, whereas the pulmonary disease was more common in stem cell transplant cases. Again, just adding to the list, there are many other case reports and this case series, which is again showing the same. Before concluding, I would like to thank the organizers, and a special thanks to Tamra ma'am and Arvind sir and Raja sir for their guidance and support. Thank you.
Thank you very much, Dr. Jesty, for this very fascinating presentation. So we've found definite evidence of a fungal infection, particularly in the lungs. And we've also successfully identified the fungus. So it is a pheohyphomycosis. And as Dr. Jesty reviewed in the literature on pheohyphomycosis in transplant recipients, we have earlier seen involvement of the skin and subcutaneous tissues with this fungus. But as she said, systemic involvement and involvement of the lungs is only occasionally seen. And this patient is one such example. I was expecting to see much more in the liver in terms of chronic liver disease. But surprisingly, we haven't found any evidence of chronic liver disease at autopsy.
Yes, sir.
And we've not found tuberculosis. And it appears that the CMV disease had already been adequately treated and had responded to the therapy that was given. The findings in the allograft were, of course, as expected and as had been already reported in the allograft biopsy. And with that, I'd like to open it to the House for comments and questions, if any.
We can have comments from Professor Joshi, Professor Jain, and Professor Ritamra. I think they can comment more on the pathology part. In any other nuances.
Good evening, Dr. Raja, and good evening, sir. So I just wanted to make two comments. One is regarding, I think we saw C4D positivity in the glomeruli also, which is generally a non-specific finding. It's basically a trapment of our stain within those reduplicated areas. And generally, glomerular positivity is not given any credence, or it is not taken into account, though I've never understood why not. Because if we are having an endothelial injury because of antibody-mediated rejection, so having positivity there, as we see in peritubular capillaries, why it should not be given any importance. But that is how the BAMF has laid out, and we just follow that way. Another point which I wanted to make was about these fungi. Generally, whenever we see septate fungi, we tend to label it as aspergillosis. But here, because of the color of the fungus, we suspected a different species, and that's why we had submitted tissue for PCR, for species analysis. Because generally we don't do the species analysis on all cases, but the identification of that brown color was the point why we wanted to give this tissue for a species analysis. And the third point is about the liver. I just was wondering, even at the time of clinical presentation, why, Dr. Gauri, you considered a chronic liver disease with an acute element? Because was there any radiological evidence, or because low albumin could be because of our renal situation?
Regarding the, can I, ma'am?
Yeah, sure.
There was radiological evidence which was suggestive of portal hypertension, ma'am. We had portal vein of around more than 12 millimeters. We had high sag ascites.
Okay.
So there was radiological, even the ascites was high sag. So that point towards more towards a portal hypertension as a cause of this thing, ma'am. It is.
But as we've seen in these few couple of photographs, and we reviewed the slides again when we sat together, but there was no really evidence of the deep blue color within the liver, which indicates presence of fibrosis in any location, either centrizonal or any bridging fibrosis. So that is little kind of not congruent with the clinical details, but presence of those cholestatic areas was indicative of sepsis-induced changes. Thank you. I think that's all I want to add to it. Yeah.
Professor Jain was supposed to say.
Yeah. One thing I like to comment, in one biopsy, there was hyalinosis in afferent and efferent both arterioles, afferent and efferent arterioles. That is more indicative of diabetic nephropathy, as is indicated by Dr. Gauri and Dr. Sapuja also, that this was post-transplant diabetic nephropathy patient was having. Another thing I wanted to know, that chronic active antibody mediated rejection was diagnosed, and it was plex was given, treatment was given. Then what was further changes in autopsy? Because two biopsies separately, I think I have not seen. So in one biopsy, we saw chronic active antibody mediated rejection changes. And later on, at the time of autopsy, in the nephrectomy specimen, what were the changes? Chronicity changes. Yeah. And another comment I wanted to make, that in recent band, just like Dr. Tamra is saying, that in glomeruli, there is no C4D positivity significance has been given. So in recent band, they are now including veins and venules. There's some significance they are attaching, apart from peritubular capillaries, C4D positivity. So maybe in next, it will be coming in veins, C4D positivity, endothelium of veins. So you can comment on what were the chronicity changes in the autopsy in graft nephrectomy.
Yes, you can take the question.
Yes, ma'am. So the the antemortem biopsy that was done outside, and we don't have the slides for that. In the postmortem, changes, the chronic changes are one is transplant glomerulopathy. There is double contouring of the glomerular basement membrane, the capillary wall. Second thing, the other changes, there are chronic TMA changes in the form of, there is mesangial matrix expansion, there is segmental sclerosis. And coming to the interstitium, we have an IFTA of 40 to 45% with a CT and CI score of 2.
So when patient was treated, plex was given in September, and patient succumbed in November, probably 3 months, after 2-3 months. So during that, patient not adequately immunosuppressed, or treatment was not effective, because patient was having chronic active antibody mediated reaction in the graft, allograft tissue also.
Regarding the immunosuppression, sir, there could be a high chance that this patient was on limited immunosuppression because he had CMV disease, received ganciclovir during that time. So it's very likely that his immunosuppression other than steroids would have been withheld. So I agree that, that is one thing. He would have been only on little immunosuppression, which could have resulted in an accelerated.
Yeah.
Just one comment, like we had seen the EM at autopsy, and as we saw that there was no glomerular basement membrane thickening or loss of trilaminar structure, which is one of the earliest change to be seen in diabetic nephropathy if it happens to occur in glomeruli. Though presence of afferent microvascular injury, as Dr. Manoj mentioned, that there was afferent and efferent noted somewhere in the pictures shown. So that was there, but there is no evidence really of a glomerular effect of diabetic changes which were there, because EM did not show any, because EM changes are the earliest to be noted in diabetic nephropathy.
Okay.
Yes, you are right, because GBM thickening, which is diabetic nephropathy earliest changes, but patient was having superimposed chronic TMA-like changes. Just it has been nicely demonstrated, endothelial injury, reduplication. So that might be masked or maybe early changes. But as per literature, afferent and efferent arterial halitosis and patient was, so that can be coexisting diabetic changes may be there in the biopsy.
Yeah, but the point against recurrence of against occurrence of diabetic nephropathy was that the diabetes was detected only in 2015, and the patient died in 2016. So that would be a very short duration of diabetes.
Diabetes. Okay.
Yeah, that's why.
And patient had, I think, suppose a good glycemic control also. So because diabetes is usually, we have noticed that they usually coexist with other diseases. So that if one sees carefully, one can get subtle findings of diabetic nephropathy apart from other coexisting, whatever the primary disease is there.
I agree, sir. But the duration, 1.5, because these patients are on close scrutiny with respect to the, at least for the diagnosis of diabetes in the post-transplant setting. So we wouldn't have missed diabetes. So 2015 means he would have been diagnosed as a diabetic truly in 2015 only. So within 1 year, developing diabetic kidney disease is less likely. Diabetic nephropathy.
You are right. It takes longer time for 5 years at least to develop some consistency.
Yes. Madam?
Ma'am Joshi can comment something.
No, I don't. Hi, I don't really wish to comment on that. I see. But if the kidney has a transplant glomerulopathy with the TMA changes, which is seen in 30% of transplant glomerulopathy, and PTC2 and C4D2 would be part and parcel of a chronic antibody-mediated rejection. Would it be called a chronic active antibody-mediated rejection in a situation where IFTA is already about 50%? That was one of my kind of comments. And the other comment is about the presence of, very thick C4D positivity in the glomeruli in TG. And most of us, like Rikambra, myself, and anybody else, have seen that this is a finding often seen, but not consistently seen. And that's why I think Rikambra, in her comments, gave the answer that why it is not used as one of the criteria for calling it a, transplant glomerulopathy. Also because it's an entrapment, and almost any cause of a thickened or duplicated GPM does produce C4D positivity. So basically, I think it's an indicative of how badly the GBM or the pseudo, or the duplicated GBM is affected rather than what has kind of caused it. So that's it, and a beautifully demonstrated and beautifully documented case. Although I did think that so much cholestasis in sepsis-induced acute liver injury, I have not really seen, such extensive cholestasis in sort of visible so nicely in the scanner view. That left a little doubt in my mind. Rikambra.
Thank you. So if there are no further comments, then we can close the session. But before I close, I'd just like to suggest to all the residents who are listening to the CPC that they might go through a historical review of the Banff classification that has just been published in Kidney International recently, that describes in detail how the Banff classification has evolved over the last 30 years. So that gives you an overview of the changes in the classification that have come about during this period. So it will be very useful to go through this. With that, I'd like to thank all the participants, my co-chairman, and Dr. Raja in particular for the opportunity to participate in this second North Zone CPC. A very interesting one indeed. Thank you very much indeed.
Thank you.
Thank
Thank
you.
you all. Thank you all.
Thank you, sir.
Bye.
Bye, Raja, and everybody.
Thank you, everybody. Bye.